Hello guys, in this lecture we are going to learn about IGA nephropathy, also known as Berger disease. So IgA nephropathy is characterized by the presence of prominent IgA deposits in the mesangial regions along with recurrent hematuria as a clinical presentation. So there are prominent IgA immunoglobulin A deposit in the mesangial regions of the glomerulus, which is leading to recurrent hematuria in the affected people. So this is known as IgA nephropathy. So remember, this is the most common type of glomerulonephritis worldwide. Okay. And what is the diagnostic criteria for IgA nephropathy? There must be glomerular IgA deposition in the mesangium. This is a classical identification. One more thing that you need to remember is that these IgA deposits can also be seen in other systemic disorders such as Hinoch-Schönlein purpura as well. Okay, Hinoch-Schönlein purpura. So in IgA nephropathy, IgA deposits are seen. But if IgA deposits are seen in a kidney, it doesn't mean that the person is suffering from IgA nephropathy. There are also some secondary causes of IgA nephropathy such as liver diseases and also intestinal mucosal defects. Now let's understand the pathogenesis of IgA nephropathy. Okay, this is the most important point. Listen to me carefully. What happens? Normally, IgA are secreted in the mucosal lining of the respiratory tract, GI tract, and as well as the urinary tract. And these are the main immunoglobulins secreted in the mucosal membrane. So there are two existent forms of IgA nephropathy. The immunoglobulin A is present in monomeric form as well as the polymeric form. Monomeric form is present in the plasma at low concentration, and the polymeric form is not at all present in the plasma because they are catabolized in the liver. So what happens? Normally we have IgA in two forms, monomeric form and polymeric form. Monomeric form are present in plasma at low concentrations, and polymeric form are catabolized in the liver, so they are absent in the plasma. So what actually happens in IgA nephropathy is that these polymeric IgA are present in the plasma, and they have something called as the hinge region. So to this hinge region there is attachment of galactose containing sugar chains, also called as O-linked glycans. So there is attachment of galactose containing sugar chains, or also known as O-linked glycans, to this hinge region that is present in the polymeric IgA. And what they will do, these polymeric IgA, there are two pathways. One, they can directly, or this aberrantly glycosylated IgA, they can directly go and deposit itself in the glomeruli. Or what happens, these glycosylated IgA will further generate an autoimmune response in the body. So upon the generation of autoimmune response, there will be antigen and antibody complexes, also called as immune complexes, and these immune complexes as well go and deposit in the mesangial matrix. So we have aberrantly glycosylated IgA, which are nothing but as the polymeric IgA, in which we have attachment of the galactose containing sugar chains or O-linked glycans to the hinge region. They can either go directly deposit themselves in the glomeruli in the mesangium, or they can generate an autoimmune response in the body, which leads to immune complexes and their deposition in the mesangial matrix. Upon histopathological examination, we see that this is the entire glomerulus. So this is the entire glomerulus, and in these glomerulus you can see the deposition of the central, what all you can see, these are all the mesangial proliferation. This is the histopathological specimen of the IgA nephropathy. So what happens, there will be activation of the mesangial cells. When these IgA antibodies will go and deposit in the mesangial matrix of the glomerulus, there will be activation of the mesangial cells. This leads to mesangial cell proliferation. There will also be recruitment of the inflammatory cells in the mesangium. Finally, these all inflammatory cells will lead to glomerular injury. There will also be activation of the complement pathway, in which we can see elevated levels of complement 3 proteins, but the complement 1q and complement 4 are absolutely absent in the glomerulus. So this is the main pathophysiology of the IgA nephropathy. So we have the aberrantly glycosylated IgA, either it can directly go and deposit in the glomeruli, or it can form an immune complex and go and deposit in the mesangial matrix. In histopathological specimen, we can see mesangial cell proliferation, and this actually leads to recruitment of the inflammatory cells, leading to glomerular injury. There will also be an activation of the complement pathway, that is elevated levels of complement 3 proteins. So what additional history we need to know, that it can also happen in a familial situation. So family history will also be present. It is also most common in the HLA identical twins as well, and it's also associated with MHC class 2 loci susceptibility. So this is additional points that you need to know. So what are the other secondary causes of increased IgA that leads to IgA nephropathy? We have the most common, that is the acute infection following GI or respiratory, but it can be caused by virus, bacteria, or it may be autoimmune response to the food proteins. This acute infections leads to elevated levels of immunoglobulin A, which will go and deposit in the glomeruli. It can also happen in gluten enteropathy, also known as celiac disease. It can also happen in intestinal mucosal defects, some liver defects, as well as if there is a defective hepatobiliary clearance of IgA, which leads to increased IgA levels and their deposition in the glomerulus. So the other secondary causes of increased IgA, these are all the things that you need to remember. Finally, coming to the microscopic morphology. So upon light microscopy, what you will see is a glomerulus, and in the glomerulus we can see mesangial widening. So mesangial widening we can also see endocapillary proliferation of the mesangial cells. So these two are the classical features of mesangioproliferative glomerulonephritis. So this IgA nephropathy, in which we can see mesangial widening along with endocapillary proliferation, we can say that this is similar to the mesangioproliferative glomerulonephritis, also known as MPGN. In some of the glomerulus, we can see only segmental proliferation of the mesangial cells, so which is similar to the focal proliferative glomerulonephritis, FSGS. Sometimes it can also appear as crescentic glomerulonephritis, also known as RPGN. So these are the three different modalities that IgA nephropathy can present with, either MPGN, FSGS, or RPGN. On immunofluorescence, what we can see we saw that there will be IgA deposits in the mesangium. So mesangial deposition of IgA can be seen in the immunofluorescence, and along with IgA we can also see complement 3, propyridine, and also less decreased amounts of IgG and IgM also will be seen in the mesangium. As you can see, this is the immunofluorescence picture of the IgA nephropathy patient. We can see that there will be mesangial deposition of the IgA antibodies. So on electron microscopy, what do we see? On electron microscopy, there will be electron dense deposits in the mesangium as well as the capillary deposits. So these two are the classical features that we see on electron microscopy of a IgA nephropathy patient. Moving on to the clinical features of IgA nephropathy, it is most common in older children and young adults. So what do you mean by older children and young adults? Somewhere age between 10 to 30 years. So this is the most common age affected. The patient can suffer from gross hematuria following an infection. It could be a respiratory infection, upper GI, lower GI, or also urinary tract infection. So upon these infections, there will be increased levels of IgA, immunoglobulinemia, which will lead to increased levels of glycosylated polymeric IgA and their deposition in the glomerulus. So 30 to 40% of the patients can also suffer from microscopic hematuria with or without proteinuria as well. And the patient suffers in episodic patterns. It can happen after a few months and repeatedly over the years. So slow progression of IgA nephropathy is seen. Slowly it will progress to chronic renal failure or chronic kidney disease. The percentage of people around 15 to 40% of the patients per year are slowly progressing towards chronic renal failure or chronic kidney disease, and this happens over a period of 10 to 20 years. And what are the increased risk of progression? Increased risk of progression to this IgA nephropathy is old age, and patients who are having heavy proteinuria, people who are hypertensive, as well as if there is so much extent of glomerular sclerosis on biopsy of the kidney. So these are all the four risk factors which will lead to increased risk of progression. So yes guys, you can access these notes by becoming a member of the whiteboard doc. So click the join now. Thank you guys, thank you for watching, and ending the lesson with thought for the day. Every day is a new chance to do something good. So remember guys, every day is a new chance to do something good, something better, and something extraordinary. Thank you.